Thank you very much, Romy. Dear all, I would like to give you an overview on the ACLF, especially on the clinical aspect, especially also for the younger colleagues of ours. What is the current status and also some recent advances, especially some insight from the PREDICT study. So the natural history of liver cirrhosis, you may know it. This is also the cartoon from the MicroPredict grant application. We have, of course, the stable cirrhosis, who are patients who are usually at home. They come and visit us every 3 months to 6 months or a year. They are stable, they do not have much complaints, but sometimes they develop decompensations and then they go into the hospital. Usually they get ascites, which is one of the clinical signs, or especially the clinical signs that defines decompensation. Once they get in the hospital, which happens when they are decompensated, the mortality is less than 1% per year. Nevertheless, there are few of these patients which may develop acute and chronic liver failure in 30% of the cases, and they have a more severe syndrome with acutely organ failure and other clinical signs which I'm going to outline in the next slides. These patients are usually admitted to the ICU or emergency room or on the ward, and they receive drugs, infusions, and they have a very high mortality of 40% in 28 days. And this is the reason why we are so interested in ACLF. I would like you to put on the screen also the ACLF definition, which is defined as a syndrome occurring in cirrhosis characterized by acute decompensation, several clinical signs which may occur in these patients, development of organ failure, and high short-term mortality. And this is a syndrome which is usually not only confined to the liver, but also the other organs start to fail. And I would like to outline my talk, so I will talk about the diagnosis, grading, then development of ACLF, precipitating factors, clinical course, some ideas on the pathogenesis or whatever, or what we think it may be the pathogenesis of ACLF, and some management or prevention of ACLF. So regarding diagnosis and grading, as I said in the beginning, not only the liver, which is defined by the bilirubin level, but also the kidney, the brain, coagulation, circulation, respiration, they are all organs which may fail. And as you can see here, there are several thresholds for each organ function, and we define ACLF in different grades, or we grade ACLF when either there is a renal failure with a creatinine over 2, which is ACLF grade A or grade 1 or grade 1A, or a single non-renal failure with creatinine between 1.5 and 1.9, and or hepatic encephalopathy grade 1 or 2, so not brain failure. And this is again ACLF grade 1B, and then 2 organ failure, 3 organ failure, and more organ failure than 3, 4 or more. This is ACLF grade 3. And as you see here, there is an increase in mortality in these patients from 4% in 28 days in patients with acute decompensation without organ failure to 18 or 28% in ACLF grade 1, between 18 and 10 to 80%, then 32 up to 90% in patients with ACLF grade 3. So we have a dramatic increase in very short-term mortality rate in these patients. How does this develop? What is the basis for ACLF? As we said in the beginning, cirrhosis is the basis, or ACLF occurs in cirrhosis according to the Easel-Cliff definition. So we have a diseased liver, and usually in patients with decompensation, portal pressure is increased, so hepatic resistance in the patients with liver cirrhosis is increased, thereby portal pressure is increased. Reflectory, we have splanchnic vasodilation, so the vessels in the splanchnic area, they get wide, and this leads to a decrease in effective blood volume and increase in cardiac output. And the heart has to work more in order to perfuse the organs, but this increase in cardiac output leads to a further increase in splanchnic perfusion and thereby increase in portal pressure. So we have a vicious circle here, which aggravates the hyperdynamic circulation. When this situation lasts for a longer time, then we have a decrease in effective blood volume, which is associated to a decrease in perfusion of different organs, and especially the kidney and the brain are very sensitive and they start to fail. That's why kidney dysfunction and also cerebral dysfunction or hepatic encephalopathy are so important for the definition of ACLF. And then ACLF occurs, and they may, and during the ACLF, different organs may be dysfunctional or may fail. But looking into the preceding events and looking into the first study which characterized ACLF, which is the canonic study, we see that there are patients, 40% of the patients have bacterial infection, 23% of the patients have active alcoholism, 30% have more than one preceding event, different events, and we have up to 43% of the patients who do not have any preceding event. That's why we performed the PREDICT study. The PREDICT study included many of you here in the audience, recruited patients in 53 centers which applied to participate, and 47 patients included at least one patient, and we recruit together 1,300 patients prospectively, patients without ACLF, in order to see whether when this ACLF develops. And in this portion of patients, 18% of the patients developed ACLF within 3 months. And the question is, what do we see in the patients, or what is the clinical course? From the canonic study, we know that the patients are younger, the patients who develop ACLF, than the patients who do not. They have more ascites and they have more alcoholic liver cirrhosis, and also they have organ failure by definition. And indeed, bacterial infection not only precipitates ACLF development, but also complicates ACLF. As you see here, bacterial infection in the follow-up in patients with ACLF has a similar outcome as patients with bacterial infection as a precipitant factor for ACLF. These are data still from the canonic study. Once ACLF develops, we have to think, if they recover, what happens with these patients? And as you see here, the role of previous decompensation seems to play a role. If you look into the data from the canonic study, we do not see a clear interaction between the patients who had previous decompensation and the patients who did not have previous decompensation compared to ACLF or not ACLF development. However, in the PREDICT study, we observed that there was a first acute decompensation reported by the patients at admission was much more near, timely, to the patients with unstable cirrhosis and to the patients with stable cirrhosis. So this means that ACLF in the patients in the pre-ACLF group occurs, they have a shorter history of disease. It occurs very close to the development of ACLF. And ACLF, once it happens, it is very dynamic. You see here, this is the paper from Thierry Gusteau, which was published from the canonic series. And you see here that the course of disease may be very different. And dependent on what happens in day 3 to 7 after development of ACLF, this is what also will defines best the course of disease in these patients. So the patients who are after 3 to 7 days ACLF grade 3, they will have a very high mortality, almost 90% mortality within 28 days, compared to the patients who are ACLF grade 3 at enrollment. So it is very dynamic. Nevertheless, after stabilizing for a few days, then we will know the course of disease. The question is, what is the pathogenesis? What are the reasons, or what are the key pathogenic mechanisms of development of ACLF? We know already that if you compare patients with ACLF and without ACLF, and also according to the ACLF grade, leukocyte counts increases, also CRP increases. So we suspect that systemic inflammation is involved because these are inflammatory markers. Thereby, Joan Claria analyzed in the canonic study all the patients without ACLF and ACLF where we obtained blood sufficiently, and also the pro-inflammatory and anti-inflammatory markers and other cytokines. And as you see here, there is a very clear difference between the ACLF group and the patients with acute decompensation and the healthy controls. ACLF group have a high systemic inflammation compared to non-ACLF, and non-ACLF patients have a higher systemic inflammation than the healthy controls. But the question is, can we differentiate due to the systemic inflammation between these two groups? And if we look into if we include the compensated cirrhosis, which we did in the canonic study, with having an extra cohort or an external cohort, then you will see that the healthy controls, looking into the pattern of the inflammatory markers, the healthy controls and the compensated cirrhosis, they cluster rather together, while the acute decompensation and acute chronic liver failure patients, they have very high inflammatory marker levels. But looking more in detail into the acute decompensation patients, then you will see that the patients who will develop ACLF at follow-up, the extent over the all systems of inflammatory markers is much higher than in patients who will not develop ACLF in the follow-up. The question is, what is the trigger of systemic inflammation? We have shown that also in the circulating blood of the patients, or this has been shown very, very nicely by Benjamin Lelouvier and Weiermeyer in the previous studies, but also we could confirm this in cirrhotic patients receiving the TIPS, that we have bacteria around, and we were looking into the different bacteria together with Manuel Umugam in the different species of the bacterial DNA we found in the blood of the patients, and we looked into a different compartment, and we saw that there were very different the compartments, and moreover, that different bacteria or levels of bacterial DNA, they correlated with biomarkers, with inflammatory markers in these patients in a specific sample. So we can suspect that bacteria may play a role in this setting. Moreover, these bacterial DNA or bacterial components, they may go into the liver, and looking again into the patients who will develop organ failure, we see that the levels of inflammatory markers in these patients are much higher in the hepatic vein than in the portal vein. This is shown here by the dark bars, so by the black bars, compared to the white bars for IL-1, IL-6, IL-10, and many other inflammatory markers. The patients showed that the inflammatory markers derived from the liver, since there was a gradient over the liver in the hepatic veins. Okay, so we have bacteria going to the liver, inducing a systemic inflammation. The question is, how can systemic inflammation be linked to organ failure? We have many evidence for that. This is one of the studies from our group which shows that the patients with acute decompensation, and also this is in animal studies, and this is in patients, we show that there is a net collagen deposition in the liver after the patient. So systemic inflammation or acute decompensation of the patients, they boost collagen formation and they decrease collagen degradation, as shown here by the different markers, the collagen formation markers and the collagen degradation markers. Also, from the group of Rajiv Jalan was shown nicely that markers of cellular death in the liver, they are highly correlated to development of acute and chronic liver failure. So systemic inflammation deteriorates the liver function. Moreover, together with the group of Raj Mukherjee, we could show that in patients, we were looking into the heart of patients with liver cirrhosis, and we could show that, you see here, the heart rate variability as a readout for functional rhythm in the patients. They have many dots, they all cluster together, but nevertheless, you can differentiate them from each other. In cirrhosis, this variability decreases. If the patients develop a decompensation, or if they are decompensated, it decreases even more. And I will show you a patient with acute and chronic liver failure. It has no heart rate variability. The heart rate variability is almost zero in these patients. So systemic inflammation, it decreases the heart function, and also it decreases the variability of the heart, so it impedes the heart to respond to stress. We have also further evidence that mitochondrial dysfunction, as shown by the FGF21 levels, as you see here, patients without ACLF, patients with ACLF at admission, and patients developing ACLF during follow-up, you have already an increase in FGF21. This was also shown by Joan Claria in Hepatology paper 2018, when we looked into the tryptophan pathway and kynurenins together with Christophe Junot's group, that show that kynurenin are crucially involved in the development of ACLF. And finally, recently published in the canonic study, we could show that there was an energetic crisis in the patients with ACLF compared to the patients without ACLF. Therefore, I would put the hypothesis and say that bacterial translocation, that's why we are looking into the bacteria in MicroPredict, leads to a leak of bacterial components into the portal vein, which goes into the liver, activates the immune system, activates inflammatory markers, which on the one side lead to death of hepatocytes, activate furthermore the inflammation, and leads to a further increase in systemic inflammation, leads to increase in fibrosis, and it spills over to the systemic circulation and leads to extrahepatic organ failure. What can we do about it? I would like just to highlight a few points. On the one side, we know that transplantation is very effective. You have patients who have been transplanted in the Canonic study with a mortality of 6 months of 81%. But if these patients will not be transplanted, then you will see that the mortality of these patients is 90%. So we can save 70% of mortality in these patients if they are transplanted on time. And this was confirmed by another independent study published from the Lille group in 2017 in the Journal of Hepatology, showing that the patients without ACLF and patients with ACLF, after transplantation, they have a similar outcome. Before transplantation, you saw already that there were very marked differences in mortality. So liver transplantation is effective. However, we have to get these patients to transplant. How can we do this? We can use extracorporeal devices. One of them is MARS, albumin dialysis. I'm showing the devices where we have some data on it. You see here the patients who were compared to standard of care, because the MARS study was performed before we knew the definition of acute and chronic liver failure, or before this was published. As you see here, it is the same time as the Canonic study. There was no difference. However, if we stratify patients receiving high-intensity treatment, so more sessions of MARS albumin dialysis, and the patients with low-intensity treatment, then you can see that the patients, you can bridge them to transplant. So extracorporeal systems, they may be helpful in order to bridge the patients from ACLF to liver transplant in a safe way. But also we have not to forget that sometimes the patients are simply too sick to be transplanted, and we should also consider the withdrawal of care in order to not to prolong too much their suffering in these patients, especially patients with more than 4 organ failures and patients with CLIF-C ACLF score more than 64, where we cannot do much more for these patients. Still, we can prevent it, and where is a challenge, there is also a hope. I would like to highlight the Liver Hope Project, because Liver Hope Project is also part of MicroPredict. This was published recently by the group of Per Agines and also the collaborators, that combination of simvastatin with rifaximin may be good to prevent acute and chronic liver failure. Indeed, this study especially showed that a high dose of simvastatin may lead to adverse events. Therefore, we should consider that a lower dose of simvastatin together with rifaximin may prevent development of acute and chronic liver failure and death in the patients. But this has to be shown in the second trial of the Liver Hope Consortium. Another trial which is very important, or another drug which is very important, is the albumin treatment and systemic inflammation, going into one of the pathogenic steps of development of ACLF. As you see here, patients receiving high dose of albumin and receiving low dose of albumin, there are two different patients. In some of the patients, you can majorly decrease IL-6 fluctuation. In others, you can't. So you have different courses, and usually the albumin treatment may help the patients to stabilize and may decrease the rate of development of acute and chronic liver failure. And this is the rationale for our ALP trial within MicroPredict. So I would like to summarize. ACLF is a dramatic syndrome with a very high mortality and morbidity. Systemic inflammation and mitochondrial dysfunction characterize ACLF development. Probably is the trigger of the microbiome, either directly, deriving from the gut, or from the circulating cells. We don't know yet that. We are going to analyze all these tissues in the MicroPredict in order to highlight this and to see the relationship to acute and chronic liver failure. And the management of ACLF is still challenging. Liver transplantation as the most promising treatment for now. Prevention of ACLF would be a better strategy probably. I would like to thank all the MicroPredict consortium and all the other groups that are, and also other grants and other consortia which are helping us, the money givers of course, and you for the attention. I'm happy to take any questions.